is peak flow or I time set correctly? It kind of goes along with what we just talked about. What graphic would alert you that the flow rate is inadequate? It's probably more for volume modes of ventilation, because in a pressure mode of ventilation, whatever flow rate is needed to reach pressure, so you get lots of flow in pressure modes of ventilation. So that question is more for volume modes of ventilation, so if you want to write that down first. Happens in volume modes of ventilation. Happens in volume modes of ventilation. Inspiratory pressure will not rise. And then you guys have to help me figure out a word. It won't rise. It won't be. It'll what? I can draw the picture.
How it won't like build?
Yes, it won't build. So pressure normally should go, keep rising throughout inspiration. But if you don't have enough flow, then the pressure will kind of sag or lag behind, and you'll get more like something like that, where instead of it being a smooth rise to pressure, yes, a smooth rise to inspiratory pressure, the pressure will build. Pressure won't build. Pressure will not build adequately.
Pressure will not build adequately.
Because there's not enough flow. Yeah.
That one looks similar to the graphic we saw today. It just has an extra like little line that comes up there. So
Yeah, that was a
it's
strange
a
graphic.
strange graphic.
There's some more examples of ventilator asynchrony. So you would ask yourself, well, do I have my trigger sensitivity set correctly? And I think you're getting used to what the normal values are for setting sensitivity on the ventilator. Pretty much all of them, when you turn them on, they have default settings for sensitivity, and those are adequate almost all the time. So you usually don't have to play with your trigger sensitivity. There's some exceptions to that. Patients that have prosthetic heart valves, when they have prosthetic heart valves and the valves close or open, it causes a change in the flow going into the lungs, and it can actually initiate breaths. And you'll notice that the patient's respiratory rate and the heart rate are the same. So in that case, you would have to go from flow by into a pressure sensitivity setting to prevent all the auto triggering. What about rise time? Is rise time set correctly? So you would adjust rise time in patients that have air hunger. Very good. Adjust rise time in patients that have air hunger. They are going to need a fast rise to pressure because they're starved for air and they're trying to get a lot more air in. So you would give them a faster rise to pressure if they are air hungry. Another example of asynchrony is not enough pressure support. You would notice, what would you notice, or how could you tell if you have enough pressure support?
Work breathing.
Work of breathing you could look at. What else?
What mode are we in?
Pressure support. How could you tell if you don't have enough pressure support set? Yes, there you go. Low tidal volumes. So increased work of breathing, low tidal volumes mean that you don't have enough pressure support. We have a couple more minutes. more we do now, the better, because after lunch, I know you guys look tired now. Luncher's head is on the table. I don't know what I'm going to do. But after lunch, it gets even worse when your bellies are full. So let me go a couple more slides. All right, so you also have to chart level of consciousness. And sometimes when you're looking at the patient, you're not really sure why they're not responding to your questions. So it could just be sedation. So it's good to get with the nurse and find out. Patients in the ICU are usually on sedation all the time because it's so uncomfortable to lay in bed with all these tubes. So it could be that their neurostatus and their level of consciousness could be normal if sedation was turned off. And the other thing with turning off sedation, they have found that patients actually come off the ventilator in less days. They're weaned quicker if they have what's called a sedation vacation, where once or twice during the shift, sedation is turned off and the patient wakes up and becomes fully awake. And usually when that happens, they become very anxious and irritated, and maybe they can't stay off sedation for very long, and they end up having to be resedated. But still, just a few minutes at a time of letting them become awake. And at that point, nursing does a full assessment, a full neuro assessment to see if it's somebody without a stroke, lift your right arm, lift your left arm, wiggle your toes, where am I touch the foot that I'm touching, or lift the foot that I'm touching. They'll go through a complete neuro assessment on the patient. So respiratory-wise, it's good to be in the room when the nurse is doing that, and then you can also chart in your notes what the level of consciousness is, off sedation. But typically you're charting, sedating. If it's a patient on the floors though, now that's a different situation because they're not on continuous sedation. And you get to know the patients, that helps. But when you're walking into a room of somebody you haven't treated before, now you're talking to them to see if they're going to respond to you. And if there's nothing in the chart about a stroke or in coma or anything like that, you're expecting them to open their eyes when you talk to them, answer questions to see if they're alert and oriented.
Just to clarify, you said sedation vacation for 3 minutes helps wean the patient off the ventilator?
Yes. Yeah. Do I write that in your notes? No? Ledger doesn't think it's important to me.
No, I already wrote it down. That's fine.
Oh, okay.
I'm talking, I already did.
Yeah, I just wanted to clarify.
Yeah, I'm glad you did. Is there anything else? Because sometimes I start to rattle and I forget.
Just please repeat that as I was focused on something else at the time.
Yeah, can you repeat what you wrote?
Yeah, I put sedation vacation for a few minutes helps wean the patient off of the vent.
Thank you.
No problem.
There are definitions in Egan's Fundamentals of Respiratory Care that explain the difference between confused, lethargic, and comatose. So after lunch, I'll bring my notes up to give you the specific definitions for those. Like when do you write confused, and when do you write lethargic? So I'll give you the notes. Okay, so I'm thinking this takes a few minutes to go through airway and assessing airway. So maybe this is a good spot to start. And we'll continue after lunch.
I had to hold that. It's a literally airway assessment.
Oh, really?
I was patient with that. Afterwards, so then with the.
Oh, you did?